I'm Dr. Jay Anders, and this is Tell Me Where It Hurts, where we discuss some of the big challenges in health IT and how we can solve them so clinicians can do what they do best, care for patients. I'd like to welcome everyone to another episode of Tell Me Where It Hurts. Today's guest has been working in the field of standards and interoperability for a while, and we're going to talk about that a little bit today. And I was thinking about interoperability before the podcast and trying to figure out just how far we've gone. We've got now standards, we've got some rules and regulations regarding that, but we've not really gone as far as we need to as far as making that information useful. And I remember back when, and I'm an internist by training, when I would get a medical record from someone else, it would be 30 or 40 fax pages long to go through and read and try to correlate all in your head. I think we can do better. I think we're in the process of doing better with that going forward. But we just need to keep working at it. And our guest today is going to help us kind of decipher some about where we are and where that whole direction is going. Our guest today is Amit Trivedi. He's the Senior Director of Informatics and Health IT Standards at HIMSS, which the big meeting is coming up at the end of next week. In his role at HIMSS, he is part of the interoperability strategy across health IT standards ecosystem and acts as the liaison to the standards developing organizations, such as the National Coordinator. In addition to doing this type of work, he actually kind of came up, and we'll talk about this a little bit more, through the world of, if everybody remembers it, CCHIT. Being on the opposite side of the fence and certifying an EMR through CCHIT, I remember some of that pain very, very well, but absolutely necessary and certainly absolutely critical. So, Amit, welcome to our podcast.
Well, thank you for having me. It's really a pleasure to be here today.
So, as Senior Director for Informatics and HIT Standards, explain a little bit about what you do and what you're about.
Sure, and thanks for the introduction. And so, as you mentioned, I work with HIMSS, and most people know HIMSS through the big conference that we have, and that's about to happen in just a week or so. But within HIMSS, my team and I work specifically within informatics and health IT standards. As you mentioned, we help direct and support the standards ecosystem within HIMSS, and we also help represent our membership on various industry efforts. In fact, a lot of people sometimes are surprised to the level in which we are engaged in health IT standards, implementation, adoption, and so forth. And so as an example of that, like my team helps run Integrating the Healthcare Enterprise, IHE USA. That's the National Deployment Committee for IHE. And we run the North American Connectathon, which is one of the largest industry testing events for interoperability. We also have a cooperative agreement with the Office of the National Coordinator to help advance the FHIR specification and, more specifically, the International Patient Summary. I also help support a number of different industry efforts as serving as either a subject matter expert or on advisory boards. And some of those groups include Shift Interoperability, which is focused on the protection of granular data and privacy protection. The Interop Community, which is focused on supporting the community with open source tooling efforts. And then also Digital Bridge, helping to reduce some of the barriers and challenges around health equity. And so a lot of these efforts all really speak to supporting the broader mission and vision of HIMSS, which is reforming the global health ecosystem through the power of information and technology.
So tell me a little bit what motivated you to get into this aspect of healthcare.
Well, that might be a little bit of a lie down on the couch type session, but so it goes back to I can paint the picture. So I went to undergrad at the Johns Hopkins University. So like many of my peers, I was interested in medicine and pre-medicine. I was pre-med. My undergraduate was actually the history of medicine, science, and technology. And that kind of spoke to my interests, which were definitely medicine, definitely science, definitely technology, but also, the liberal arts, history, art, writing, everything else. And so that allowed me to kind of pursue multidisciplinary approach. But then I graduated right around, Y2K. And so that was about the time where everybody was getting sucked up into technical type roles, things like that. Just a little bit more about me personally. At that point, I was also interested in pursuing, my musical career and furthering my interest in, playing in a band, etc. And so wound up graduating from Hopkins, working in the Howard County Hospital radiology department as folks were transitioning for Y2K and helping modernize and moving to electronic health records, et cetera. And one way or another, I found my niche. It was that intersection of technology, healthcare, people, policy, is a little bit of everything. And while I was still interested and still am interested in music, that's always also been my passion. Health IT, improving healthcare, finding ways to advance medicine, not being a physician, And so I found myself, working at Howard County Hospital, then moving through the ranks in, IT work, focusing really on security, disaster recovery, those types of things. But then wound up getting pulled back into healthcare with a third-party insurer. And so wound up working with basically claims and the whole movement to digitize claims adjudication, and really that was my first taste of issues around HIPAA, ERISA, different things related to interoperability and the complexities of faxes and PDFs and illegible handwriting and payments and you name it. And so I wound
Yeah, I
up.
find that fascinating. To be honest, I was going to be a music teacher before I went to medical school. That was my passion as well. So I understand that totally. And I find a lot of people in healthcare, whether it be technical or whether it be actual delivery, have this musical background. It's something about that that just seems to drive us into health care
Without a
fields.
doubt. And we somehow find each other out as well, like seek each other out. So that'll probably be a topic for a side discussion as well. But basically, my career just progressed moving further into health IT. I worked with groups like the National Alliance for Health IT, Certification Commission for Health IT, Verizon's ICSA Labs, and that led me to kind of what I felt was like my dream job at HIMSS, being able to kind of represent the industry, our membership, which spans both patients and providers and technologists as well.
So let's turn to the subject of structured clinical data and its role in interoperability in the industry as it is related to the standards that have been created, USCDI, as well as 21st century cures, that's now become a reality. And there's a little bit of enforcement that's going to be announced or has been announced for that. So what do you think the role of structured data plays in the interoperability landscape?
Well, in my opinion, it's really all about the structured data. And that's what we've been driving towards for years, right? Like we talked about faxes. We live in a world of, clinical documents. But we're moving to a world that's going to be designed around FHIR, fast healthcare interoperability resources. And really the beauty of FHIR is being able to support interoperability at the most granular levels. And so that really speaks to the importance of structured clinical data. And if you see the various efforts within the industry, like 21st century cures, US CDI. All of these efforts help complement the emergence of FHIR to help interoperability and advance interoperability and being able to exchange granular health data. And so as an example, the US CDI initiative is helping us as a community to identify and define the core data that must be transmitted as part of health information. And then even that initiative, US CDI, is branching out into things like US CDI Plus to be able to cover the structured data that's specific to more niche and special communities like public health.
So speaking of those data standards, and FHIR is a data standard in its transmission, what are some of the key drivers in the progress of that regarding the standards that are being created in the interoperability right now? And what are some of the big challenges that you see when this finally starts to really be truly interoperable as far as the healthcare IT system is concerned?
Well, and so as you mentioned, there's quite a few drivers that have been moving the adoption and advancement of standards forward, like meaningful use, the promoting interoperability program, 21st century cures, et cetera. And as interoperability progresses, we still have additional challenges. And so I think one of the biggest is around cybersecurity, security and privacy of that health information. And another is usability of that information. I think you alluded to 40 pages of faxes earlier in our conversation, but now we're looking at potentially hundreds of pages of clinical data, right? So sorting from all of that information and information overload. And then I think one other big issue is around health equity and those disparities that seem to increase as we apply more technology. We've probably mentioned this, it's a world of haves and have-nots, and sometimes technology exacerbates those issues as opposed to making them better.
I absolutely agree with that. When I talk to people from rural health providers, including my little hometown of 19,000, it's a wholly different landscape than you see in, say, a Chicago or a Pittsburgh or a New York. And they somewhat at times do feel left behind. That's absolutely correct.
I 100% agree with that. And, in my role at HIMSS, or throughout my career, I feel like I've been focusing on interoperability at a much higher level, national or international level of interoperability. But working with HIMSS, our local chapters, I see exactly what you're talking about. And the issue is that we need to be helping our local, regional, and state providers and health organizations and those entities just as much with interoperability as we have to kind of advance this at the larger levels with the big national networks, the big large vendors, the big health systems, et cetera. So rural health is absolutely, the last mile is a big piece of interoperability. We can't have these big holes when we're talking about national or international coverage.
So we talked a little bit about 21st century cures and the enforcement thereof. And I think that's a great thing. A stick sometimes is needed to move people along and keep people on the rails. But there were 6 quality health information networks that were recently announced. How do these companies or data lakes or whatever you want to describe them as, how do they play in what your work is and in the industry?
Yeah, so one of the things TEFCA will help push forward is the network of networks, right? Because what we really need to have is to scale interoperability is to have more of those entities hooking people up to the network, right? So it's not going to be one group, it'll be multiple groups, and then multiple groups looking at different specialties. So some of those QHINs may evolve to address the needs of a specific group. But that said, The challenge is still going to be, and when you talk about things like data lakes, looking at all that unstructured data and making sense of it, and also ensuring that there is the proper level of security and privacy enforced as well. Because we talked about things like the FHIR and the promise of being able to unlock data at its most granular levels. At the same time, the challenge there is to ensure that the metadata or other information is also present so that things like privacy, consent, authorization can also be tackled as we're looking at the exchange of information. And so related to this, I think one of the biggest challenges, and it's something that we've been kicking the can down the road for years around, is electronic consent or consent of information. And so we are working in a number of different areas to address that, and most notably with folks like Shift Interoperability. And in fact, we're working with the Stewards of Change to do an e-consent learning lab as part of our HIMSS pre-conference activities. But the issue of consent is really important, and I bring it up often with these groups in the context of health equity and equitable interoperability. And if you don't mind, I can explain that a little bit more. The idea of equitable interoperability stems from the fact that when we're looking to share health information or health records, oftentimes when a patient has a complicated health record, meaning information around substance abuse or things that would normally be sensitive, we often don't have the ability to protect that information at the granular level. And so when information or records are complicated, the default is often to not share. And so what we find is the folks that need interoperability or could be served the most by it, the folks with complicated health records, are the folks that are not getting it. And so that's an example of that issue of technology, in some cases exacerbating the issue as opposed to making it better. Until we figure out a way to granularly protect patient data, we're going to be dodging this or working around this issue.
I find that very interesting because that really has not changed in my medical history in this industry. I remember having conversations. We were a multi-specialty group clinic. We had psychiatrists, we had multiple patients, we had a unified medical record, and they fought clinic leadership tooth and nail to keep their medications out of our unified medical record. And the argument was, you're exactly right, is those are the kinds of things we all need to know so we don't hurt somebody. They're on some drug that we don't know about or condition we don't know about, and we launch off that road. So I absolutely am sensitive to that. And I'm curious about your assessment of how the resistance to sharing some of this has changed in the 20 or so years you've been doing this.
Well, I mean, I think we see a generational shift, right, in terms of privacy, identity, the ability to access information on demand, right? I think if you look at just 10-year gaps, like the whole the ideas around that have shifted, right? So folks today have a whole new expectation around getting data, whose data it is, when they should access it, who should see it first. All these things come up, and I think the younger folks are going to be driving this forward. And so I see less resistance to sharing that data. I think I heard it on a previous podcast, folks were talking about, releasing lab results, right? Immediately when the lab results are recorded. And that may be before a provider gets to review that. With you. And this is a dinner topic at home in the Trivedi household because my wife is trained as a genetic counselor. And so if you can imagine what we're talking about in terms of genetic privacy, being able to release lab results about perhaps prenatal or cancer genetic test results without having a professional to help interpret those results. There's a lot there in terms of, what would be the proper way. But I think most people agree, or I've seen many people feel that, the data should be in the hands of the patient. They have that option whether they want to review it by themselves or with a provider. At the end of the day, I think the philosophy is do no harm. And I think the tough part is the changing, the attitudes around maybe whether it's a patriarchal attitude in terms of who should be addressing these issues and ownership, or whether things should be patient mediated. These are all a part of the swirling, changes that we're dealing with. But I see that, the direction seems to be clear that we're giving patients control of their data, or we should be.
Which I think is absolutely the right place it belongs. When you see this data, and you mentioned this in one of your other comments, that we're going to go from my 40 pages of faxes for one patient to literally 1,000 different data elements coming across in some way. So how do you see providers interacting with that? Because I can see pluses and I can certainly see minuses as to the volume, the breadth of what you're going to see, and how do you actually focus on the data elements that really you need to focus on?
And throw in patient-generated data as well in that mix. And that just explodes, the amount of information there. And so, in my opinion, the only way we're going to be able to get through this is through the support of AI and using those types of technologies to help sift through the information and present the right information at the right time to the right person, which of course is a tall order and may segue us to the next topic around artificial intelligence and healthcare and some challenges around there as well.
So are you concerned about how providers and other folks that are accessing this make sense of it all?
I am concerned because, if you look at any industry, right, information overload is an issue, right? Like, so easy analogy, pilots and dashboards, right? How do they manage all the different alerts and notifications going on? It's a safety issue, right? Same thing goes for a provider looking at all the different inputs coming in. And so I think it's a task well beyond any human. We're going to need that intervention from our technologies. And so then how do we get AI to support us, right? It goes back to having that structured clinical data. It goes back to having the metadata and the additional context and provenance around that, because at the end of the day, with these huge data lakes, with all this information coming at us from all these different sources, the provider, the system, whoever it is that's looking at this data is going to need to make sense of it, knowing where did it come from, when was it recorded, is it something I can trust, is it the most recent, what do I do with this data?
So how do you see HIMSS involvement in all of what we just talked about, meaning how providers are going to decipher it, how it gets transmitted? What do you think HIMSS's role is in this?
Well, so, it's interesting because I think it's the issues that we're talking about are not just a technology issue. They're not just a policy issue, and they're not just personnel, workforce, people issues, right? It's that combination thereof. And I think that's where we need, that multidisciplinary, collaborative approach of pulling in the stakeholders, and even HIMSS, like, we need to do a better job of pulling in the right people or more people at the table, whether it's a more diverse representation of folks, getting folks that are outside of the traditional healthcare spaces and getting their involvement as well. And one example is I've been working very closely with the EMS community to support interoperability with emergency medical services. And they're often seen outside of the healthcare system, right? Often seen as just transport, and it's in everything from the policies to the payments to the data that's exchanged. So like I think there's a lot, as the composition of our stakeholders changes, and it is because we're talking about more people, we're talking about more specialties, more entities outside of traditional healthcare, especially as we start to talk about social determinants of healthcare. We need to make sure that we take all those perspectives into account. And so that's where I think a place like HIMSS is the right place to convene folks and to at least get those conversations going and pull the right people together to move forward.
So on the stick side of 21st century cures and the compliance thereof, what do you think HIMSS role is in like getting involved with the enforcement or education, or especially with the EHRA members that you have, things like that? So give us a little flavor about how you think HIMSS is going to interact with that.
Sure. And I have a little experience just because in the past I was not at HIMSS. So I would rely on HIMSS to do some things to help support my various programs. So while HIMSS may not directly get involved in the actual compliance or enforcement, you did mention the education piece, right? And that's really where we can help support, whether it's educating our various stakeholders, members, or getting the feedback from our various communities back to the agencies. So you mentioned the EHRA, and so they've been an incredible group in terms of being able to pull together a single unified voice for the vendor community to react to various regulations and policies put forth by ONC. And to their credit, if you've ever checked out any of their public comments or any of the reactions, I mean, they're thorough and solid, and they put a lot of effort into that. And as I deal with other communities, whether it's LTPAC, EMS, et cetera, they look at groups like the EHRA to see like, well, how do we get a similar kind of traction or leverage in the space? So back to your question about the enforcement of 21st century cures, I think there's still a lot of questions around the enforcement, right? Especially when you look at things like the exceptions around information blocking. Those are always, if I was a vendor, that's where I would be looking directly at. And then there's always, some squishiness to some of the regulatory terminology, right? Like no special effort, right? That's the API access rule. So, special effort might mean something different to me, it might mean something different to you, and obviously something different to HHS or OIG or any of those enforcing bodies. And then ultimately, until we see that enforcement happen, or the industry does, that's when they'll know it's for real. So an example is for like, say, meaningful use and the certification. I spent, a decade certifying electronic health records at 2 different entities. And, and from meaningful use stage 1 to, the most recent. And it started out as, pretty loose because there weren't the test tools, there wasn't the experience. It was like, show us how interoperable you are almost, But then eventually the compliance piece came down, right? And there were a number of penalties that were handed out and things like that around False Records Act, things like that. And then you bet people resubmitted their attestation, made sure that they had dotted all the I's and crossed all the T's, and they approached certification and testing with a whole new perspective after that. And so I'd expect once there's some enforcement penalties laid down, that should definitely get everyone's attention. But up till then, people will be trying to figure out what exactly will this look like. And the cynic in me wonders like how much of this will be a real penalty versus a cost of doing business thing. But the penalties seem to be pretty stiff.
I think it'll get people's attention once they finally roll out. We're kind of coming up to the end of our time, and I asked the same question of all my guests. If you had a magic wand and you could wave it and say, this absolutely is going to happen in healthcare IT, what would it be?
That's a big question. And, there's so many things I would love to see happen. I'd love to see just better improved access to care for folks, because I think that's the big thing around health equity. But if I want to push it back to standards and interoperability, I would like to see a more concentrated and a bigger bucket of funding to help support interoperability as a public good. Like we've been seeing talks about health data utilities. We've seen, the role that HIEs play. We know that there's a lot more that needs to be done in terms of interoperability. And so many of these projects and efforts are just starved for the resources. And honestly, COVID, if it hasn't improved anything, it's made things worse that were already worse, right? So you see a lot of these projects just struggling. And so I would love to see more funding to support interoperability, and have that funding set up so these public goods are shared across states, across jurisdictions, things like that.
It has been a pleasure to have you on our podcast today. If someone wanted to get a hold of you and ask questions or comments, how would they do that?
Well, you can come find me at the Interoperability Showcase at HIMSS in Chicago in a couple of weeks. You can pop into any random standards work group, and I'll probably be sitting on that too. But you can also contact me at HIMSS, Trivedi at HIMSS.org, or on Twitter at A3VEDI. But I would love to, I'm always interested in following up or talking shop with interoperability enthusiasts as yourself or the audience. So I just wanted to say thank you again for the opportunity. It was such a fun conversation, and we could probably talk for another 2-3 hours if we had
at least. Thank you so much. That's all for today. Thanks for listening to Tell Me Where It Hurts. Tune in to Healthcare Now Radio and Podcast Network each month for the latest episode. To learn more about Medicomp systems, visit our website at www.medicomp.com. You can also follow us on Twitter at MedicompSys, or myself at MedicompDoc, or check out the show notes for links. See you next time.